So thank you very much. It's great to be here. And I'm going to talk about pragmatic trials, what, when and how. It's a sort of journey over the past 15 years. And if you thought that I was going to give you an idea of what you should do, when you should do it, and how you should do it, like a cookbook, that's not what I'm going to do. I'm going to give you a few examples and some reflections. But I'm going to start with my journey yesterday. So I came by boat. Well, it's not me, actually. My PA had been on the website and booked a ticket for me. And so I had a plan to get the boat at 2 o'clock. Unfortunately, the boat was delayed. We didn't leave till 4:30. When we did leave, the sea was quite rough. Though I didn't really notice, because I know what to do on those boats. You just take a tablet and lie down and keep still and you're fine. But I know from the conversation with the people on the table next to me that some people were not fine yesterday. And eventually I got here. And as I was thinking about that, I wanted to use that as a kind of metaphor for doing a trial. You know, we might have a good plan at the beginning. Unfortunately, there are often delays. Some of those have, in my view, got worse over the past 15 years. I don't know what it's like here. I don't know that there's much that I can say about some of those delays. But what I want to talk about more is that kind of bit where you actually get on the sea and it's quite rough. It doesn't go exactly as you might have planned. But also talk about where you want to end up at the end and whether, in fact, we are getting there with pragmatic trials or not. So one of the reasons for focusing on the past 15 years is there's been a 12-fold increase, roughly, in the number of things calling themselves pragmatic trials. Let's not go into whether people label correctly or not. And a 19-fold increase in methodology papers over that time, though obviously there's a much smaller number of methodology papers, but still they have increased. So there's been this quite rapid and noticeable increase over the past 15 years. But I want to go back and start a bit further back than that, over 50 years ago. Most people will know, I expect, that the first people to use the word pragmatic in relation to trials were Schwartz and Eldridge in this seminal paper in 1967, and they make this distinction between pragmatic trials, where you're helping to choose between care options. It's a trial that helps you to make a decision about something, and explanatory trials to test causal research hypotheses. With explanatory trials, what you're really trying to do is gain information. And that's the distinction that they make. Now, obviously, if you have a trial, you may be both trying to help people make a decision and trying to gain information. And they recognise that in the paper, that these two things may not be mutually exclusive. 30 years later, Rowland and Torgerson have this paper in the BMJ where they describe the difference between pragmatic trials and explanatory trials as pragmatic trials measuring effectiveness and explanatory trials measuring efficacy. So effectiveness, the benefit that treatment produces in routine clinical practice, and efficacy, the benefit treatment produces under ideal conditions. One of the issues I think with that is if you think about effectiveness as the benefit a treatment produces in routine clinical practice, a lot of pragmatic trials, at least the trials that I come across, are actually trying to change routine clinical practice. So it doesn't quite work. But those two definitions have stood the test of time, although over the past 15 years it's been recognised more and more that actually this isn't a dichotomy. We haven't got explanatory trials over here and pragmatic trials over here. We've got something more like a spectrum. And so it might be more sensible to ask this question: how pragmatic or how explanatory is a trial, rather than whether it's one or the other. And one of the useful pieces of work, very useful pieces of work in relation to that, is the Pragmatic tool. I can see Sean sitting in the audience, and I can't for the life of me remember what Pragmatic actually stands for, but I'm sure he can tell you later. But the Pragmatic tool is a tool that was designed to help researchers design their trials and to think about this pragmatic explanatory continuum and where you want the trial to sit on that continuum. So the idea is that you have 9 domains and you score each domain from 1 to 5, and if you score everything 1, then you've got a very explanatory trial, and you can map it onto this diagram with that little tiny circle in the middle. It's not quite a circle, that's because I can't draw properly, but it's meant to be. If you score 5 on all of them, then you have a much larger circle on your diagram, and that's a pragmatic trial. So these 9 domains, and I'm not going to go into detail about the domains, but just to give you this as an example of one of the tools we can use when thinking about pragmatic trials and trying to unpack those different domains or ideas about what a pragmatic trial might be, or at least what a trial at the pragmatic end of the spectrum might be. So these are my words, they're not words out of the tool itself, but these cover those 9 domains. And so if we're doing a very pragmatic trial, we want to help make decisions, help people make decisions in clinical care, then we want a group of participants who are representative of those participants who might eventually get this treatment. If we move, I'm not going to go through these all, but if we move down the table, for example, flexibility in delivery, we know that in the real world, out there in clinical practice, there will be flexibility. So we want to allow clinicians to have the kind of flexibility that they might have if they were doing this, using this intervention outside a trial context, so that we have some idea of whether this intervention really works if it was to be delivered outside a trial context. Moving further down, we want the primary outcome to be relevant to participants versus the explanatory trial, where we're not that interested in whether the outcome is necessarily relevant to participants, but there's some information we want to obtain about how that intervention works, how it acts on participants, but we don't necessarily need the the outcome to be relevant to them. So we've done a piece of work within the Pragmatic Clinical Trials unit looking at how this works for the trials in our unit, and we were called the Pragmatic Clinical Trials unit, so you might expect that our trials would be at the pragmatic end of that spectrum, and indeed many of them are. But if you look at these different wheels that have been produced for the different trials, you see they're not all that lovely big circle shape. They've got various kinks in them, which represent areas of our trials where the trial was not designed in such a pragmatic way. Interestingly, if you look at the top right, Riva 2 and STOP, and also HEP3, so the yellow, green and blue, and the blue one at the top in the middle, they were all cluster randomized trials. This is a tiny sample. I'm a statistician, so I'm not going to draw any complete conclusions, but just a hypothesis from that cluster randomized trials may in general be more pragmatic than other trials. So here's a reflection, and I know that it's not only me who's thinking about this at the moment, a reflection on what is a pragmatic trial. So that quote at the top is from Schwartz and Alouche. Should one prefer the goal of immediate applicability, i.e. helping people to make decisions with the sacrifice of true understanding, or the more distant goal, which may lead to greater enlightenment and which may prove more fertile for the future? Okay, that's obviously written over 50 years ago, but it highlights really the idea that the difference between these trials is something to do with intention. What are we intending to do with our trial? With the Pragmatic tool, what we've moved to is thinking a lot more about how we design these trials. What are the features of these trials? And so I think there's this tension between what we intend to do in a trial and how we design it. And how do we define pragmatic trials in that context? Is it just about the intention, or do we have to pay attention to all these different design features and make sure they're at the pragmatic end of the spectrum as well? So, when do pragmatic trials arise? I'm going to give you 3 examples in a moment, but I'm going to start with drug trials, because a lot of people think, when they're thinking of this spectrum of trials, that we start with a drug at the explanatory end and we move towards the pragmatic end. So we start in ideal conditions, early phase trials, and we gradually move to pragmatic drug trials in routine practice. And that's often called the translational pathway, and we start at the left-hand end with basic science, and we end up, bench to bedside, but it's often not bedside, it's often in general practice or in another setting. But that's drugs. Our experience with trials in the Pragmatic Clinical Trials Unit is that most of the trials that we do, virtually all of them in fact, are not drug trials at all. But this is an example of one of the trials done in our trials unit, which does involve a drug. And this drug was montelukast, which is used in other settings. But the question that the investigators had in this trial is, can we use it for children who have wheeze, small children who are wheezing, in order to prevent unscheduled medical attendances for wheezing? So the idea of the trial was that this was not so much a trial of the drug itself, but if you gave packets of the drug to parents and explained to them when they should use it, could parent-initiated montelukast achieve what the investigators wanted to achieve? And the control in this case was a placebo. So this is the Précis wheel for that trial. And you can see 2 distinct kinks in there, one in recruitment. This is because what we wanted to do initially was to recruit in primary care. That proved very difficult, and most of our participants were recruited in secondary care and elsewhere. So that's why recruitment looks like that. And follow-up, obviously giving parents something to give to their children, these parents were followed up much more closely than they would have done, than they would have been in routine practice. Okay. Second trial is a cluster randomized trial of smoking cessation through pharmacies. So our population was pharmacies. The idea was to help those who came in through the door of the pharmacy who were smokers to stop smoking. The intervention was training and support for pharmacists, and there was no training and support in the control group. This is what the Précis wheels look like, and we did 2. One at the cluster level, where it looks quite pragmatic, one at the individual level, where some of the domains weren't relevant, so that's why they scored 0, but still it looks reasonably pragmatic. So just a little bit about cluster randomized trials. I'm sure everybody in the room knows about cluster randomized trials, but in a cluster randomized trial, they don't always, but usually they have 2 groups, an intervention group and a control group, just like an individually randomized trial, but here we randomize clusters rather than individuals, and so we randomize a group, and in this case, the clusters that we were randomizing were pharmacies or individuals who came into that particular pharmacy, but we take our measurements. I don't know whether you can see that, it's very faint. We take our measurements on individuals, so we get this difference between the unit that we're randomizing and the unit that we are collecting information on. Okay, the third trial is quite interesting. So this is a trial looking at negative symptoms of schizophrenia. So our population was people with schizophrenia, and the outcome was measured on a well-known scale, the PANSS scale, for symptoms. And the intervention in this case was body psychotherapy. That is a picture off the internet of body psychotherapy. I'm not a therapist, so I don't know exactly what goes on in these sessions, but it looks Well, it looks interesting. But we did have a control in this trial, which was a little bit like a placebo. There was a feeling that we wanted to look at the active ingredient of body psychotherapy, which you can see from that top diagram as a lot of kind of touching. But we wanted something where a therapist had the same amount of time with people. But it wasn't quite like body psychotherapy, so there you can see we had Pilates, which is a bit different. So a lot of pragmatic trials don't have placebos, but this one did. We were still trying within this trial to help make a decision about whether to use body psychotherapy or not. There was no explanatory trial, like in a drug trial. There was no early phase explanatory trial. It would have been difficult to do the trial any other way. You could say that it's got explanatory elements, so if it had a positive result, we might want to do another more pragmatic trial. In fact, it didn't have a positive result, so we're not going to do that. So to summarise those three trials, when can pragmatic trials be done? In translational research, when we're trying to take findings from basic science to enhance human health and well-being, and that's the standard one, I think, where most people think pragmatic trials are done. But in STOP, we were doing research on stopping smoking. We already know that helps to improve health. So here, we're not really trying to find out anything about the stopping smoking as an intervention, but how do we actually implement stopping smoking in a pharmacy? What's the best way to do that? So you could call that implementation research. And with the third trial, NESS, there wasn't any other way that we could see of doing that trial other than the way that we did it. So how should these trials be conducted then? And I'm going to talk about 4 things, and I'm going to give you just a couple of examples as we go through. Just a plug, we will later next year sometime be having a whole day on pragmatic trials at the Pragmatic Clinical Trials Unit. So if any of you want to make the reverse crossing over to the UK to that, then you'd be very welcome. But I'm just going to give you 5 minutes or so. So I think the first thing to think about when designing one of these trials is what is the intervention. And often it's not, as I've said, a drug. So in the case of weight, we have parent-initiated Montelukast casts. So the intervention was the mode of delivery, really. Can we do something by helping parents to deliver rather than professionals? Intervention is often, in my experience, training and support, which is aimed at health professionals and in the case of the STOP trial, other cluster staff, so not aimed specifically at participants. And sometimes, as with the body psychotherapy trial, NESS, we're not saying to people that the intervention is the treatment itself, but the intervention is the offer of 6 sessions of body psychotherapy. Whether people come or not is up to them. And I think one of the things in designing pragmatic trials is to try and be really, really clear about exactly what your intervention is. And also some good development. So over the past probably longer than 15 years, there's been a huge increase in the number of publications with intervention development in the title. This is a hot topic for some people. And there are lots of frameworks for developing complex interventions. The earliest one, probably the MRC, the UK MRC framework for developing complex interventions. The Precy tool, another framework that I've just showed you. We've written recently about defining feasibility in pilot studies and have a conceptual framework in that. This ADEPT framework looks at how you make the decision following a feasibility study about your complex intervention and your main trial. And then there are a raft of papers by Pat Hodinott and Alicia O'Kahan and others about developing interventions, of which this is just one. So if you want to find out about developing interventions, there is a huge amount out there. What about ethics and regulation? I'm sure nobody would disagree with me that we want studies to be ethically sound. That's one of our aims, but we also want them to be scientifically sound. And we also want them to be feasible. And sometimes those things can appear to conflict with each other. So just one example on informed consent, and I'm not going to go through this in detail, but just raise these questions with you. It is sometimes the case that depending on the informed consent processes, depending on what you're telling people about the trial that they're in, can affect the pragmatic nature of a trial. Sometimes telling people anything about the fact that they're in a trial could have a more serious consequence, could actually conflict with the science and cause bias. And I won't go into detail about the particular example where this occurs, but in cluster randomized trials, there are a huge number of cluster randomized trials now, and there are still quite a lot which are biased because of the way or the timing of recruitment and informed consent. So I think we need to think about different models of consent, possibly waivers of consent, and where they are appropriate, because actually if we can't do the trial scientifically, then my view is that it's not ethically sound either. There are other ethical issues around that sort of trade-off between ethics and science, and there's a piece of work that I'm involved in at the moment, funded by the Canadian Institute of Health Services Research, where we're looking at ethics in particular. And one of the important things, I think, in that piece of work, and one of the things that I would make a plea for, is the science, the regulators and the ethicists to get round the table and talk to each other, because otherwise there can be huge misunderstandings. So, bias. This is a definition of the internet. Bias is any tendency which prevents an unprejudiced consideration of a question. So first of all, we've got to be really clear about what our question is and where might bias arise, where might we not be able to answer that question as we wanted to. So here's the question for the weight trial. Does parent-initiated Montelukast prevent tendencies for wheeze in preschool children? And basically, bias arises when individuals respond to information. I mean, we all know about this these days with even thinking about recruiting staff. You know, if you've got information about ethnicity, about age, that can bias how you recruit. So it happens in other arenas as well as trials. In an explanatory drug trial, what we do is we blind through a placebo and make sure that nobody involved in the trial knows which group people were allocated to, not the patient, not the person delivering the drug, etc., etc. But in a pragmatic trial, it's often the case that we can't blind. So some people have access to some information. And the question is, who should have access to what information and who shouldn't in order to prevent bias? So I'm going to give you just 2 examples. Okay, this is not an indication of what I think about chief investigators, but it may be the case that information is valuable to some people because they can use it, and it's not so valuable to other people. So if you've got a pragmatic trial where you haven't got a placebo, so your trial is not blind, then some people in a research team will know which individuals or which clusters are in the intervention group and which are in the control group. And I think in that case, one of the areas where you can get bias is if the chief investigator has access to interim results. If the interim results don't look as good as they want, then they have quite a lot of influence over people in their team to ask them to do something differently in the trial. Or they may also have influence if the statistical analysis plan has not been signed off over how the analysis is done. Okay. Some of you may have seen this. This is one of my favourite slides. So this is a cluster randomised trial. Anybody like to guess what the intervention is? HATS. Okay, so it's in the States. It's a trial on screening from the sun. And so in this case, if we had individuals who were going to go and collect outcome data from the clusters, that would be quite difficult to do. You'd have to tell the children not to wear their hats that day. Then they'd all be saying, oh, we've been told not to wear our hats today, and that wouldn't work. So it can occur in other cases as well. So another cluster randomized trial that we did, I haven't got time to go through the detail, but this is a picture of Iris, and the trial was about domestic violence, and this picture was stuck up in all the practices, posters, stickers on computers, etc. So everybody knew, or everybody who was part of the trial would know as soon as they went into a practice whether it was an intervention or control practice. So in this trial, we had independent researchers who weren't part of the trial, who went into some of the practices and collected the data, the outcome data in the practices, to validate our outcome collection for most practices, which was done by researchers who did know whether the practice was in the intervention or control. So lastly, reporting and analysis. So this is the consort statement for pragmatic trials. Of course, I would suggest that you follow that. So one of the interesting things recently has been some discussion around the analysis of pragmatic trials, and most people would say use an intention to treat analysis. That gives you an idea of what's happening, even if nobody participates as they should do in the intervention. We know, we get a result which takes that into account, so we know what's going to happen if we roll this intervention outside a trial context. But there has been some work recently by Hernan and others talking about per protocol analyses in cluster randomized trials, in pragmatic trials. And their argument is that you need the per protocol analysis in order to be helpful to patients. So patients will know, if I take this drug perfectly, this is what will happen to me. We could debate what we think about that, but they have made quite a strong argument for having per protocol analyses in pragmatic trials. And that's to support patients' decisions, but it doesn't, of course, support the decisions of policymakers and planners who would still want to know about an intention to treat analysis. So one of the things I've been thinking about recently, so I don't know how many people in the room have partners. I'm talking... Life partners, yeah. If you've got a life partner, how did you choose your life partner? And if I was to say to you, sorry, go back and just choose your life partner on the basis of your one primary outcome. It's that's not the way we make decisions. So if we're really trying to help people make decisions in pragmatic trials, what should we be doing? A fixation on one primary outcome, is that okay or not? And then, so Pawson and others have made quite a lot of statements in various papers fairly recently about, and I realise I've got grounds for divorce there. That might have been subconsciously connected with the life partner discussion, but it's not intentional. That's just one paper that he has written about how much decisions depend on context, and how we should see pragmatic trials as part of a much wider investigation. It's just one small brick in the wall to understand how to make decisions. So that's my summary of what I said. I hope I've left enough time for questions because I wanted to do that. Thank you very much.